The broadcast is now starting. All attendees are in listen-only mode.
I might just be a little bit late. I have to go get something for school. Can the online people hear me? Can you hear me well? I know there was a problem yesterday, but I think we fixed it. So audio should be good for the online. Thank you. Okay, we're going to be doing pediatric diseases. In fact, that was really my first announcement. I had not really understood the concepts of blocks and stuff like that. So I know you have a big test Monday, right? So this is how we're going to do it. Today is Tuesday. We will probably finish most, if not all, of the discussion on infectious diseases today. And then tomorrow, we will do a big infectious disease lab, and that will involve the virtual microscope. That'll be slide viewing and discussion about, the clinical aspects as well. And then let's see, so tomorrow is Wednesday, and then the day after that is Thursday. We may do some more lab on Thursday, but before the end of the week, and I'm thinking it's probably Thursday or Friday, we're going to do our review. And we're going to do a very surgically guided review of everything that we discussed, with particular emphasis on the fact that I was asked to submit 4 questions from infectious disease. Now let me show you something just out of curiosity. I mean, I don't know, maybe this is a coincidence or something, But this happens to be the PowerPoint. Now look, I'm going to put it into multiple modes. Now I know there's a lot of yellow stuff on there, and I told you originally that the yellow stuff is what I consider the most important stuff, and that's the stuff you're going to be concentrating on. And I feel that, like, if you really know the core stuff, and you can use it and understand it solidly, when it comes to this integrative time, for the big exam, which is called step 1, somehow you're going to do okay. So, but in addition, I've been asked to submit a very specific number of questions too. Now, I've been asked to submit 4 questions from infectious disease. So let me ask you this. How many green slides are on here? 1, 2, 3, and I think there's one that you'll see here that just has a little green outline. Okay, that's why, I firmly believe that, you're only supposed to serve, one God, not multiple. So we're all focusing on the USMLE, and I do not intend to create anxiety. Now, this little so-called method is not something I invented myself. It was invented by the person who taught me many years ago for the same reason. He never told us why his review sessions were like totally focused in on his questions. But I think reading his mind many years later, he's very elderly now. He's in his 90s, and his health is not the best in the world. And I went to visit him before I came here, and he still is a very enlightened, brilliant man. And this basically is a little method I learned from him. So that's why when I tell you, even though you don't believe me, when I tell you 1,000,000 times, don't worry about my exams, don't worry about my exams, worry about the big exam, I really mean it. So for those of you who have chosen to be here personally, that's very nice. For those of you who have chosen to watch the movies or will do whatever you want to do on your own, that's okay too. But the review is going to be right here. And most likely it will be, let's see. I don't know when it'll be, but probably within the next couple of days. Then after your block on Monday, we will start with pediatrics, and that may take 2 or 3 days. I don't want to feel rushed, whatever amount of time it takes. And then after that, we'll do the chapter on immunology. Now, I understand you're taking an immunology course right now, and I'll say the same thing for your immunology course, like I said, for your microbiology course. It's not my goal to repeat in just a few days what you're going to be taking a whole course in. So I'm going to try to bring the whole thing more in lines with, human pathology. Does that answer your question? Okay, now this was the other question or statement I wanted to make, or announcement. And we kind of screwed up. We cheated the online people yesterday because in the first half there were technical problems with the microphone. And I don't know why, but in the second half, if you've tried to download the session from yesterday, the audio was not good. When I was standing right over here, the audio was fine. When I was there, you barely heard me. So in a few days, I ordered a wireless microphone, which will solve the problem. We have a bunch of wireless microphones in the school, but they're all geared for broadcasting for the speakers that are in the auditorium. None of them are USB, for a computer. If any of you have access to a wireless computer USB mic or headset, I would be very happy to steal, buy, or borrow it from you for a few days until I get the one that I ordered a few days ago. So that was the only other announcement. I don't like to sit here, but I know at least now that the online people can hear me well. And if I go wandering off into the sunset there, they're not going to be cheated. Another thing is, like, in the apartment that I'm renting now, there's a couple of these big lazy boy recliner chairs, and they absolutely are very invitational for slouching. And I know that if I slouch for a long time, like when you go to China on a plane, you have to sit for 16 hours. you almost have to slouch. Usually my back is very, very bad. That's what happens when you get to be an old man, okay? So I like the fact that I'll be sitting now anyway. And I'm very sorry to take your job away from you. I know you're disappointed, but you may never do it again, or depending on when the wireless mic arrives, I may ask you or whoever you would like to put the hex on to do it. So we have a nice cozy number here. You know, that's fine with me. And I think if you had downloaded my PowerPoints, you know, yesterday or last week, you would not have seen the four little green guys corresponding to my 4 questions. But if you download them now, you'll see them. And I don't think you can download them from here, though, can you? You have to be on the school desktop, right? Okay. Well, you might want to do that at some point in time. And you might want to also tell that to the people that are not here as well. So the other thing I was going to say is that we may be rushing it a little bit today, but now that I understand the block system better, we have a lot of time and we can proceed at the speed that we want, and we might even have some extra time. And I wanted to also say you have not been to the pathology lab yet. It's something I kind of take credit for, because when I go to all of these, you know, ASCP national meetings and College of Pathologists, they always have these guys that have microscopes connected to computers and, you know, beaming live microscopy back and forth. But it always falls short when you try to beam it to, you know, hundreds of people. Well, this method here, by using offline viewers with webinar, basically enables me to beam it up to 100 different people in the world. I'm sorry, 1,000 different people in the world. Now, do you remember this is where we sort of ended yesterday? And we're talking about the clinical classifications of viral infections. And it's also one of my green slides. And we talked about diseases in terms of clinical rather than pathologic, acute versus chronic versus latent. And we put all of the, most of the common viral infections that we're going to go into a little bit into these 4 categories. The ones that you would call transient and acute clinically generally fall into the category of the things that you'll never see because there's vaccinations for them, but people my age probably had them when they were kids. Measles, mumps, polio we avoided. And a lot of kids in my neighborhood contracted it. West Nile, or the so-called arthropod-borne viral CNS infections, those are all clinically transient and clinically acute. Almost all of the viral diseases that can be grouped into the clinical category of chronic and latent, meaning it's chronic, but it may be like totally inactive for a large period of time, often years, are practically all in the herpes family. And even though they don't always have herpes in the name, like cytomegalovirus or varicella zoster, these are all basically categorized into the taxonomic division of herpes. We'll be giving examples of all of these. The most obvious one that fits the category for chronic are the hepatitis viruses. And even though they can be called A, B, C, D, E, and who knows, maybe by the time this class is over, they'll discover an F. They're basically things that are chronic, but they generally don't become very latent, as opposed to the herpes family, chronic and latent viruses. And lastly, the ones we can't ignore, and the ones that I actually heard Dr. Jalan mentioning to you about, are the so-called transforming viruses, the viruses that have the potential to cause cancer, if not absolutely directly, certainly interacting with the mechanisms that I heard you learn about in the concepts of carcinogenesis. So we'll skip through the other ones for now and just go with the viral ones. The first category, transient, acute, measles, mumps, polio, West Nile. And even though you may never see it, because they generally don't exist in the so-called developed, vaccinated countries anymore, sometimes they occur in undeveloped countries as outbreaks. Otherwise, Very rarely you'll hear of, in the United States or so-called developed countries, of, measles or mumps or polio. I think for the most part, polio is eradicated forever. Okay, so probably one of the most common businesses or customers or patients for a pediatrician many years ago was a small child, preschool or school age, breaking out in a rash, having been preceded by an upper respiratory infection for a few days, in which there was a sore throat. And even though the picture down here in the southeast generally precedes the maculopapular rash that you see here in the northwest, it was very often, when you would look at the throats, pharynges of these kids, they would have little spots. And you might not be able to really appreciate little spots from this particular picture because it's a lousy one. So recently I went to get a better one. And do you see these little red and white, almost like peppered little spots on the mucosa? Those are called Koplik spots. And the thing that made the pediatricians look really, really smart is when a kid came in with a regular sore throat, which half of their kids do, and they had these little Koplik spots, that was a sign that they were going to be breaking out with a skin eruption a couple days later. So it was almost like they were forecasters of what was to come. And the parents always thought that the doctor was so smart. Now, measles is caused by a virus, and it causes an infection. There are inflammatory changes in the skin. And it was generally not really feared, but there was a small percentage, I'm thinking maybe 1 or 2, that were very, very seriously involved. Measles also caused a pneumonia. Measles also caused an encephalitis in the most severe form, and the very small percentage of kids that died of measles died of the encephalitis. Now, I think you'll appreciate in the general main portion of this picture an inflammatory infiltrate. I'm imagining this is probably from the lung, but could it have been from somewhere else? I guess so, but it looks like most likely lung. Might be seeing what might be a remnant of either a small bronchus or something here. Now, in our differential diagnosis of giant cells, the most common of one we discussed the other day, giant cells, the multinucleated macrophages or multinucleated histiocytes, in which they are sharing their cytoplasmic mass for the purposes often of defeating a bigger enemy that they can't take care of on their own. These are fusions of epithelial cells. Okay, the measles giant cells are not macrophages. They are fusions of epithelial cells. You would never know this. You could probably just take this giant cell out of context and say, this is a typical Langhans giant cell of tuberculosis. But this is a fused cytoplasmic epithelium caused by the measles virus. Okay, so that's the pathology of it. Now, another common disease, which you'll never see and is well vaccinated in nicer countries, is mumps. And mumps, like measles, was spread through respiratory droplets, okay? And it is probably the major, in fact, to tell you the truth, it's the only thing I could think of right now that would be a cause of a parotitis, chiefly parotitis. It could be other salivary glands in kids that occurs in epidemic proportions. Mumps still occurs very rarely, but for the most part, it might not affect, 80% of, Mrs. Sister Mary Jones's, a second grade class. And classically, you see the swelling, could be bilateral, usually a little bit more unilateral, in anatomically the exact area which is the parotid gland, okay, at the angle of the jaw and extending inferiorly and a little bit anteriorly. That would also be the same exact location for a parotid tumor, wouldn't it be? Well, people that have a mixed tumor, the most common benign tumor of a salivary gland, also called pleomorphic adenoma, would be likely to have a more well-defined nodule in that area rather than a general swelling of the whole gland. Now, you're looking at some microscopic down here, and it looks like there's some little round structure, and you can see infiltration by acute inflammatory cells. There's really nothing here that's diagnostic of the virus itself, and you're probably thinking, well, you know, that looks like it's probably, you know, inflammation of the parotid gland. Well, that's a seminiferous tubules, because in boys, you know, mumps was also the #1 cause of an orchitis as well. And another thing which I'll be very happy to tell you is the third tissue or organ in both boys and girls that was involved by mumps were pancreas. And you're probably thinking, well, what really should the pancreas have to do with the parotid gland? So let me ask you this question from histology. If I was to show you a picture of a normal pancreas, you know, in our virtual microscope, and I will at some point in time, and I took away the islets of Langerhans, could you tell if it was a parotid gland or not? I couldn't. You know, maybe somebody could if they really looked, but to me, parotid gland, you know, 100% serous acini rather than mucinous, looks exactly like a pancreas in terms of its, you know, lobular and acinar configuration. So that's it for mumps. Did I want to say anything else? You probably have access to the lecture notes. Sometimes I'll throw a little more stuff down here if I want to mention it. But I think we pretty much covered all this stuff. What about polio? Okay, the #1 feared disease before Dr. Jonas Salk came in the 50s and wiped it, one of the biggest killers of children off the face of the earth. And he didn't do it for money reasons. He did it strictly for humanitarian reasons, something that we have a hard time understanding these days. The polio virus, whatever it is, even though we know it affects the anterior or ventral horn cells of the spinal cord, sort of preferentially, it's primarily a virus that involves mostly lymphoid tissue and intestinal mucosa. So when the virus first comes in, you generally have a sore throat, like just about every type of viral thing. It'll ultimately involve not only intestinal mucosa, but lymphoid tissue, okay? The Peyer's patches or submucosal lymphoid tissue, and also the lymphoid tissue of the tonsils. And there's some very specific receptors, if you want to learn those here, and some very specific cells. I don't think it's worth, you know, mentioning them or expecting you to memorize them, because I don't think I know any pathologist that would know the names of these cells. Ultimately, it'll get, you know, in the bloodstream, and I think you could recognize this as a real neuron, and you see some processes coming out of it, and you could also see some inflammatory cells around it. This neuron here may not be directly positively wiped out yet, but if you go on to a lower power, you'll see areas in the central nervous system or the ventral or anterior horn region of the spinal cord, which are edematous and gliotic and even demyelinated, if there's some myelin stuff there, because edema, gliosis, and demyelination are the 3 nonspecific pattern of reaction to any part of the central nervous system, whether it's brain or spinal cord or anterior horn area of the spinal cord. And incidentally, you know, just as long as we're looking at this neuron here, I just thought I'd throw something out here. Often you look at a neuron in histology and you see all these processes coming out of them, and you automatically think, well, the fattest one should be the axon. But very often you're wrong. I'll tell you a little tip if you don't know it already, and I mentioned this in my, you know, histology series as well. We all know that this granular blue RNA substance is so-called Nissl substance. in the body of the neuron, right? Well, for some reason, Nissl substance sort of very readily kind of oozes into the dendrites, but it's usually stopped short of the axon. So even though this, in this particular cut, it looks like this is not the thickest process coming out of the body of the neuron, it's probably the axon, because there's a very distinct, abrupt ending to the Nissl substance before you get into it. That was just a little side trip. Now, everybody is in vogue about West Nile these days. But if you go to a bigger picture, all of the arthropod-borne encephalitis are basically also acute clinically, and they're transient. And, they very easily may recur, even though some of them could result in severe CNS damage. Very, very large majority of them, including West Nile, are not going to kill you. Now, the thing I wanted to point out with West Nile and the other viral encephalitides, which we went over in much greater detail with the Pathology 2 group, is the pattern of reaction at the cellular level. Even though the disease is acute clinically, if you look at the pattern of perivascular inflammatory cell infiltrates, like here, in a bigger degree here, and a medium degree here, these are not acute inflammatory cells, are they? These are cells with nice round nuclei. These are chronic inflammatory cells. So when I told you originally that the general rule is acute inflammation is neutrophils, chronic inflammation is lymphocytes, I told you there were some exceptions to that rule, and this is one of them. So acute clinically, chronic pathologically. It means even though, and another thing to remember is that we spent a lot of time on this in the Path 2 group as well. Even though we call this an encephalitis, non-specific term for inflammatory disease, in this case, an infectious inflammatory disease of the central nervous system, the pattern of inflammation is almost always perivascular. So the thing to take home from that, which will be true almost all the time, I couldn't think of somebody tricking you otherwise, is whenever you're looking at central nervous system tissue and you see blood vessels cuffed, C-U-F-F-E-D, by inflammatory cells, chiefly lymphocytic inflammatory cells, that is an encephalitis, and it's most like a viral encephalitis. Okay. Let's talk about the viruses now that are chronic, and they can recur, and they can have periods of latency before they recur that could be very, very long. If you know somebody that has herpes of anything, you know that there may be an acute flare-up, and that they may be okay for months, even years, and may flare up again. And of course, the newer antiviral medications, their goal is to prevent the frequency and intensity of those flare-ups. It's generally not a situation where it's going to kill the virus forever, because the herpes family's viruses are ubiquitous. They're with us all the time. So let's go through the classical HSV, herpes simplex virus, CMV, also in the herpes family, and the varicella zoster virus. I put DRG there because it reminded me to tell you that one of the places this virus loves to hang out in is in dorsal root ganglion. So, as you know, people that have herpes zoster, rather than chickenpox, which is the same virus but a different disease at a different time of life, when somebody has herpes zoster, it's very likely, besides the fact that somewhere along the line they may have incredible pain, the pattern of rash, of vesicular rash, is often in the region of distribution of a dermatome. Okay, this is our friend HSV. Classically speaking, the oral or mucocutaneous was generally called HSV1, and the genital was HSV2. But there's so much overlap, it's almost like that's not even done anymore. The thing is to remember about all herpetic diseases is, the word herpes, they're almost all vesicular, but the word herpes doesn't mean vesicle. The word herpes means snake. So if you go to a herpetologist, you're going to a snake expert, aren't you? And the reason why they choose to use the word snake rather than vesicle, is even though they're all vesicular, is that the pattern of spread of herpes, once it starts, is generally sort of a creeping thing. It might start out as one. You may have had herpes yourself. You may know people that have herpes. You may fear herpes in your everyday life. The other diagnostic feature about a vesicle, if you scrape it, is that the nuclei of the squamous epithelial cells in that vesicle, which is basically a squamous layer filled with fluid, and that's the definition of a vesicle, is that they have these inclusion bodies. And they're called intranuclear inclusions. And in the laboratory, and I did it many times, I was asked to scrape some of these lesions from every part of a body where you could think herpes can occur, and to just do a quick little H&E stain and look at some of the nuclei and see if there were these intranuclear inclusions. And if you saw that there were, you would call that a positive Zank test, T-Z-A-N-C-K, named after a Russian guy, Dr. Zank, who invented or developed the test. It's still still done in a lot of labs. And also, in contrast now, when you go to another ubiquitous virus that's found everywhere, the definition of ubiquitous, is another herpes family virus that normally does not infect normal people, but like herpes, can affect immunocompromised people, is CMV. And if you would rather call CMV human herpes virus 5, you can. And it can infect any part of the body. It could be in the kidney, it could be in the liver, it could be in the lung. In this case, you could tell it's from the lung. And like the other virus in the herpes family, there's a big intranuclear inclusion. Are you seeing the pattern here? Now, when I show you the next slide, which you may be looking at already, because you know it's coming up, and you see another vesicle down here, and another vesicular rash, and if you scrape some of the cells of that, you think you might see intranuclear inclusions there too? Absolutely, yes. You don't see them here. You see mostly the inflammatory infiltrate, but all of the vesicular rashes caused by the herpes family, they have intranuclear inclusions. Now, I'll give you a really nice tip, and you could remember it because it's something that will help you differentiate the different viruses. In CMV, or HHV5, the intranuclear inclusion is basophilic. Okay, blue takes up the same stain as the nucleus. In the intranuclear inclusions of zoster and HHV simplex, the intranuclear inclusions are red. And that's assuming, the stain is done properly, and the histotech didn't leave the slide too long in one, and it's a good quality specimen. So, that's something you might want to remember. Yeah.
Can you diagnose with CMV with a Zank test?
CMV, if it involves the skin, but it usually doesn't. Usually CMV infections are pulmonary and renal and a few other places, but technically, if you had a surgical specimen of a lung or something that was infected, and you did a smear of that, I've never done it, and you saw a large cell with the intranuclear inclusion that was basophilic, it's diagnostic. I'll tell you something else too, now that you brought this up. A lot of times when you know that there's a viral disease, and it's, especially now in the herpes family, and you know that it's affecting or infecting a cell or a nucleus and causing a big inclusion, you know, your tendency is to think, whoa, well, that's the virus. I want you to remember again what we said a couple of times, is that no virus is bigger than a half a micron. And you see this cell here? That's a small lymphocyte. I told you that the nucleus of the small lymphocyte is 10 microns. So this intranuclear inclusion is even bigger than the nucleus of a lymphocyte. So this is not a half a micron, this is over 10. So the intranuclear inclusions are not viruses themselves. Now I know your second question would be, well, even though it's not the virus itself, could it have the virus in it? Or a million viruses in it? And the answer is yes. But the viral inclusions themselves are not the viruses. Okay, let's go down to the classical prototype of a chronic viral infection. And even though many of the hepatitis or hepatitis things, whether you call them A, B, C, D, E, they share many, many, many common features histologically, and there are ways of differentiating one from the others purely on a histologic basis. But usually the way to really diagnose them is through serology, is to do, you know, measurement of antibodies of different types. The thing I want to say in general about the chronic viral infections, hepatitis, is that even though they're called A, B, C, D, E, they're not related in any way. I think most of them are RNA viruses, but they're not, I don't think any of them are in the same family. So if you would like to generally rule out for now hepatitis A, even though it's probably the most common worldwide, it's also the most mildest, and not a very, very large fraction of the world population has antibodies to A. Most of them never knew they have it. And even though there's a fatality, it's very, very, very low, and it's not anywhere near the fatality of some of these other ones. We're also not going to say too much about D and E. We're going to get into that a little bit when we get into the topic on liver. Let's just say, even though D is separate from A, B, C, and E, when you have hepatitis D, it's almost always found in association with hepatitis B. And hepatitis E virus, of course, is different from all the rest of them too. It's not just a mild morbidity and mortality like A. It actually has about a 2% mortality. Like you would think, it's mostly common in so-called developing countries, and especially dangerous to pregnant women for some reason. So, what does that leave us with? That leaves us with only 2 letters of the alphabet, B and C. And most of your cases of hepatitis that you'll be dealing with in one way or another are going to be either B or C. And I'll give you a good general thumbnail rule. If you're in the Western Hemisphere, in the Americas, #1 concern virus is C. If you're going to be in Asia, China, India, Southeast Asia, the most virus still of greatest concern is B. So when Dr. Jalan mentioned the other day that hepatitis virus is associated with the cirrhosis, and then the cirrhosis, of course, can go on to become cancer, I normally would say, okay, well, being from the United States, I know that this hepatitis C virus is the big one for that. But actually, I went to a conference in Hong Kong a few weeks ago, and everybody was saying, well, hepatitis B virus is the big one. You know, it's because they were in Hong Kong. And so let's talk a little bit about B and C, or hepatitis in general. Now, if you go back to your normal liver, and you know this is a pretty normal liver because you can see the 3 things in the hepatic triad or portal triad, which you should see. You could see a nice big vein. You could see a couple little epithelial lined bile ducts. And I would think possibly that thicker walled blood vessel, there's probably a artery, and then you have a nice limiting plate. The only place in the liver where you have fibrous connective tissue is then that little cuff around the portal triad microscopically. And then you're basically going to be sending the blood down the sinusoids to the central vein. And the central vein is only a vein. It doesn't have fibrous tissue around it. It doesn't have any artery or bile duct with it. So the thing to remember about hepatitis is that viruses are still the #1 causes of hepatitis. A, B, C, D, or E would be the only known viruses to commonly cause hepatitis. There are other viruses like yellow fever, and even, HSV can do it under, certain conditions. But the predominant region for disruptions of this beautiful normal histology here for cases of mild hepatitis or chronic hepatitis would be in the portal area. If the hepatitis was a little more severe clinically or pathologically, you would generally see infiltrates of inflammatory cells everywhere. Now remember when I told you there were several exceptions to the rule? Polys means acute and monos mean chronic. Remember, well, I lied to you again, because even in cases of acute hepatitis, clinically, the chief cell to infiltrate in these areas are lymphocytes and macrophage, which are the mono. So here's a case here in the hepatitis where you see sort of a sinusoidal architecture. You may or may not be near a portal region here in the southwest, and you can see these little infiltrates of chronic inflammatory cells chiefly. And you also see these little red things, and I want to point this out to you. We'll talk about them again when we get to the chapter on liver, but it's worth saying in general for hepatitis. Do you have any idea what those little red things might be? They're apoptotic hepatocytes. Now normally, because the liver has cells which don't live forever, normally the hepatocytes of the liver ultimately would undergo apoptosis and die. But in hepatitis, it's sort of a pathologic apoptosis. The mechanisms are triggered off in which these cells become apoptotic in much greater frequency. And part of apoptosis, as you know, is for the nucleus to either get denser and then dissolve, karyorrhexis, karyolysis, and then for the cytoplasm to get a lot more orange. So the name for these apoptotic hepatocytes in hepatitis are called Councilman bodies. And of course, I would love to tell you that Councilman bodies are diagnostic for hepatitis B, but that's not true. There's probably, they've been reported in just about every type of hepatitis. They're just most commonly seen in hepatitis B. Okay, let's go to the last group of viral clinical patterns, and that's the so-called transforming viruses. Transforming viruses may have a phase in their life where they're doing a lot of acute damage, but it's really hard to show a picture to you of a transforming virus because by definition, these are viruses that just live in cells sort of invisibly like ghosts for many years, and then at some point in time may be a very, very key factor in oncogenesis. And I remember, because I was sitting right there, Dr. Jalan was talking about the EB virus and its relationship to lymphomas, especially Burkitt's lymphoma. And then he asked somebody, is there any type of cancer that EB is associated with? And somebody in that area over there, I was really impressed. They said nasopharyngeal carcinomas. I was very impressed that you knew that. And, but I'm going to show you what the EB virus does before it becomes a transforming virus, because it is the cause of mono, okay? Viral disease, if you want to call it kissing disease, so you know that generally the spread is by droplets, secretions, and even though it can do a lot of things. Clinically, nobody would ever diagnose a case of mono, a young person that comes in, unless at least 3 of these 4 things were present. There almost always is a very whopping pharyngitis, really red throat. Always a good amount of adenopathy. It's a lymphotropic virus. And for the same reason, the spleens are large. It's not unusual for a person with mono to have a spontaneous, rupture of a spleen. And by the same token, there's hepatomegaly. And look these are all things that you could do before you go to the order a lab test, right? So if a young person comes in and they have these 4 symptoms, very easy to diagnose, even if you haven't had physical diagnosis yet, you would then order your so-called heterophile antibodies, and that would cinch the diagnosis. They'd be really, really high. Okay, another thing to remember about mono is there are even some, believe it or not, really smart grown physicians that think that it's called mono because those funny cells that are in the circulation are monocytes. And I don't blame them for thinking that, because an atypical lymphocyte, if this is a normal lymphocyte here on the left, and it looks exactly like a normal lymphocyte. In fact, doesn't even look like possibly a little plasmacytoid lymphocyte. That's the name a lot of the lab techs might give it, but this is a lymphocyte, and the virus causes changes in this lymphocyte to make that nice round nucleus, which is such a great feature of all lymphocytes, into being more of a convoluted or irregular shape, and also a lot more flamier cytoplasm. So it looks like a monocyte, doesn't it? I wouldn't be surprised if that's how it got the name mononucleosis, because a lot of the lymphocytes look like monocytes, but they're still lymphocytes. Now, what about the transforming viruses that cause cervical cancer? In fact, I think most people would consider carcinoma of the cervix an infectious disease. Or, I'll go one step further, a lot of people might consider carcinoma of the cervix an STD, because the HP virus, or HPV virus, if you don't mind the redundancy again, will cause changes in the cells, and again, just like the hepatitis virus, it's not a direct thing, it's still conforming to the general principles of oncogenesis that Dr. Jalan so eloquently explained, of initiation, promotion, and progression. It fits into that equation, and I've heard time changes as little as months and sometimes years or decades for all these changes to occur. So when you take a person with a classical squamous cell carcinoma of the cervix and you do your molecular studies, you're going to find HPV in there. And there's always a big list, if you know that there's an HPV 18, well, there's at least 17 more subclassifications, but the 2 that are always mentioned at the top of the list, which are the biggest strains of HPV associated with this, are 16 and 18. And there's a couple of others, but 16 and 18 are the big ones. Okay, let's take a deep breath. And, we're doing pretty good. I don't feel like we got to rush anymore because we got that extra time now. So let's take a break. And I don't know, maybe we'll finish this in the next hour, maybe we won't. So what I'm going to do now is just say, expect some great music, and I'm going to ask the online people if they heard me again or if I cheated them again. Okay, online people, I'm looking at your question box, and I'm asking you the question. Did you hear me well in the first hour? Yes, perfectly. And by the way, one of our online people wanted to know where Vanna White was today. Well, I'll tell you, if you saw her, you'd probably want her here every day, but I may give her a few days off of a break, in which, thank God, you won't have to be looking at me. Okay, let's do our break. See you in 10 minutes. Yeah. Hold on, what's your name? Francesca, just like my sister. Okay. Go ahead, Francesca. I think a few people signed already.
Turn down the lights, turn down the bed, turn down these voices inside my head. Lay down with me, tell me no lies, just hold me close, don't patronize, don't patronize. 'Cause I can't make you love me if you don't. You can't make your heart feel something it won't. Here in the dark, these final hours, I will lay down my heart, and I feel I was a sailor. I was born upon the tide. With the sea I did abide. I sailed a schooner around the Horn of Mexico. I went aloft to the world that made so little blow. And when the yards broke off, they said that I got killed. But I'm living still. I was a sailor on the Mexico. I went aloft to the world that made so little blow. And when the yards broke off, they said that I got killed. But I'm living still.
Okay, it looks like that third song was a little bit chopped off, but we still had a good break, so we'll go into chapter 2 of today. The one thing that I noticed by sitting down here rather than walking around is I prefer to walk around, but when I'm sitting down, for some reason I seem to be a little bit more focused, so I don't know what I'll wind up doing. Maybe I won't be using the mic at all. That's the wireless remote mic. We'll see. Okay, we're back to part 2, and I did have a couple of other thoughts during the break. The one thing I wanted to do is to show you all something. You may have been here or you may not have been here, but this is part of my website, and it's a direct link from my main website, Medical School Pathology, and it's called Rock Lab. And Rock Lab is 500 microscopic slide cases. It's a real pathology lab. It's looking at slides in a real virtual microscope and then asking a few pathologic or clinical changes associated with them. So I normally don't like to go to the online viewer because it interferes with the webinar, but I'll just give you a quick demo here. In Rock Lab, you are actually looking at the slide. This one looks like a liver. It might even be something that we referred to recently. There may be a few questions here or a few comments, but what I've also done is take Rock Lab and made a movie for each one. So let's say, oh, you want to see what a recent myocardial infarct looks like. And that looks real nice, and you could read about it, and you could look at it, and you could zoom in and everything. But the one thing that you can also do, if you go back, is to click this other link with it, like here, and if you do that, you'll be downloading a little movie, and it'll be like about a 5 or 6 or 8 minute movie, just like I did for histology, and it'll be describing the abnormal parts of the slide and sort of throwing in a little bit of clinical information as well. So when we do our lab tomorrow, we're going to be taking the part of Rock Lab. It's divided, just like Robbins is. It's divided into chapters. And for example, here's the one on adaptations and accumulations, which was probably the first thing you discussed. Here's another one, hemodynamic. I believe that was chapter 4. And we get down to the one on infectious diseases. It's going to be quite a bit down here now, I think. I think it was pretty much near the end. There's GI, there's liver, there's pancreas, urinary tract. Oh, where do you think it is? Well, if you look at the questions that are on infectious diseases, there's a good number of them. You can see the one here on blood and lymphatics. It looks like there's only about 10 slides or so. Heart, maybe 20 or 30. But the one on infectious diseases is a bunch of slides. It's not nearly as big as the one on diseases of growth or neoplasm. But out of those 30 or 40 slides, I'll probably tonight pick out the top 20. And we'll be looking at those tomorrow. And the online people know exactly what we'll be doing. It'll be like I have a microscope here and you're all sitting on the other end. And we'll just be casually discussing the pathologic and some of the clinical features of the disease as well, because that's what pathologists do. They sit in their office, they look at slides, and sometimes people come in like surgeons and they want to see what their patient's disease looks like, and then they have a casual chat about it. So that'll be probably tomorrow. I don't know if we'll finish everything today, but we'll have plenty of time to finish this and then do the lab and then do the review as well. Okay, let's get into some of the common bacterial infections. And once again, thank God you all have had micro already. So I know a lot of this will be repetitive. And that's why, as you can see, I've chosen not to zero in on a lot of them. The overall classification, once again, it'd be on the basis of gram staining, on whether they're rods or balls, whether they take up the acid, fast stain, so-called mycobacteria, not only tuberculosis, but all the atypical mycobacteria, leprosy. The ones that have no particular stain, and you can't culture as well, like you can culture all the previous ones. The spirochetes, identified mostly by their shape, by a variety of methods. And then organisms which are deserving of the name anaerobic, frequently found in abscesses of various staining properties, gram positive, gram negative. And then the few clinical the few bacteria which are designated as obligate intracellular, having a few diseases of worldwide importance. So there you go. There's your classical gram-positive cocci. Most of them are. And without saying much more, you know that that's probably going to wind up being either staph or strep. And they have immense expression of patterns of inflammatory reactions throughout the body. You know, probably the most likely place for a staph infection is a wound infection, a contaminated wound infection. You know that there is a red rash that can be caused by staph or strep called impetigo. You know that one of the most common secondary bacteria to infect follicles, even if plain old acne is the cause, would be staph, causing a folliculitis. Staph is a very, very big agent for an endocarditis. Most of the cases of endocarditis are actually caused by strep, but in drug users, intravenous drug users, staph is always number one. Staph can make an exotoxin, that is a food poison. A staph food poisoning is very common. And then toxic shock syndrome, in which you have the staph organisms creating this family of compounds called superantigens, you know, made very, making the news a while back as being something from tampons, causing a very, very serious disorder in women. This is basically, in a nutshell, the overview of more of the common staph infections. Here's a strep infection that could also be caused by staph. Very often in the very elderly or very young or immunocompromised hosts called erysipelas. And I hope I pronounced that right, because it's not something you go around saying every day. And in this case, it's a strep infection, it's a skin infection. It's causing a very, very red rash in a woman that could very easily be immunocompromised. What about the gram-positive rods? We're not going to go into these. We'll mention them again. But if you regard all the rods as gram-negative, with these few exceptions, you could make a list of 5 or 6 common gram-positive rods. Gram-negative cocci, gonorrhea, or meningitis, most likely. Not too many other human diseases would be caused by a gram-negative cocci. Here's a gram stain. Here are the organisms. These little bent things here are nuclei of neutrophils. So these are cells that have probably been smeared from pus, either from a urethra or perhaps from a lumbar puncture, in which you're finding organisms that are gram-positive cocci. Okay, we're kind of running down this real fast. Here are the common gram-negative rods. As a review again, E. coli always at the top of the list. It seems like Pseudomonas and Klebsiella always follow E. coli. You used to remember that, you know, whooping cough, pertussis, also gram-negative rods. Yersinia pestis, the bacteria, the etiologic cause of plague, formerly called Pasteurella pestis, also gram-negative rod. And a relatively rare STD called chancroid, in the fact that it has a lot of features similar to a chancre, another gram-negative rod, Haemophilus ducreyi. And almost all of the Haemophilus are gram-negative. Okay, let's get into the ones that aren't identified by their gram staining. Tuberculosis and the pretty large family of atypical mycobacteria, most of which cause a granulomatous pattern of reaction. Also leprosy, a gram, something that does not stain by the gram stain, but is also acid-fast or stained by the Zeal-Nielsen method. Typical granuloma of tuberculosis. You can see in this particular granuloma here, you'll lose all type of identification of cellular features, and it just looks like granular, pink, cheesy, necrotic crud, hence the term caseous necrosis. You're almost always going to be finding some macrophages that have decided to share their cytoplasmic mass and form a multinucleated giant cell. In TB, these are also called Langerhans giant cells. And some of the mycobacterial infections may not be very granulomatous at all, like especially some of the atypical ones, and you'll just see, these little acid-fast organisms, diffusely throughout cells. Let's see, where are we? And this is a closer view of a acid-fast organism, and this is MAC, okay? And these are some very nicely stained acid-fast organisms. In the laboratory and in pathology, when you have a granuloma and you are looking for these organisms, it may take a long time. If the patient has been treated, or there are definitely not many of them, you may spend an hour and finally find one or two that are perfectly characteristic of it. But in a case like this, they're all over the place. This may very well have been from a culture rather than from a tissue, but in some of the immunocompromised patients, you could see like zillions of them sometimes, even in this medium power field. Okay, spirochetes. We know that basically, in terms of human diseases, we're talking about two genuses. We're talking about the treponemes, Treponema pallidum for syphilis and a couple of other rarer diseases, and the Borrelia spirochetes, and both are of the common borrelial spirochetal diseases are spread by vectors. And in the case of relapsing fever, also a Borrelia organism, it's ticks and lice, and in Lyme disease, it's deer ticks. And I'll never forget what this guy looks like because he must have been on me at one point. The causative organism Lyme disease is Borrelia burgdorferi. It's probably worth to say a few things about syphilis. It's not entirely eradicated. It's not likely you'll be seeing it, but as you know, it's not very long after the contact, the STD, the sexual contact with the organism, you're going to see a painless vesicular-like lesion on, oral cavity, genitals, and the key word there is painless, and it's called a chancre, and it's also infectious, and that chancre will eventually go away, and it'll stay painless. And then for perhaps a period of many years, there is a whole wide variety of inflammatory skin changes that could occur. And I mean, literally just about, there's probably at least 30 or 40 different common inflammatory skin conditions that are associated with secondary syphilis. The one thing that you might remember is that for some reason, the common denominator seems to be is that if you do have an inflammatory skin lesion associated with syphilis, most likely the predominant cell of infiltration is going to be a plasma cell. And that doesn't mean that every plasmacytic infiltrating a skin lesion is going to be syphilis, but it means if you do have an inflammatory skin lesion, a dermatoses, and the primary inflammatory cell, is that you might put that in a list of possibilities. And then, of course, the secondary stage can last, on and off for several years. Finally, in the tertiary stage, you can have very significant lesions called gummas, which could be anywhere in the body, just like TB could be anywhere. And gummas are very, very similar to tuberculoid granulomas, except they have a lot more necrosis and less cellular features, and they normally don't have too many giant cells. So a gumma can be thought of as being sort of a granuloma, but specific for syphilis. And to find them in central nervous system or bone is not unusual. And of course, there are the children of people with syphilis that are born with congenital syphilis as well. Anaerobes, one of the most common anaerobic infection, Clostridium, also generates gas. So when you hear the term gas gangrene, technically it could be a wide variety of bacteria causing that. Most of the time it's going to wind up being Clostridium. It's one of the bacilli If you remember, that's a gram-positive as well. Okay, this is a green one, so you know we're going to be focusing in on that somewhere along the line in the near future. And I thought I'd just bring up briefly again, and I'm assuming you've heard of these before, and may even go into more detail, the significant infections caused by bacteria which don't have gram staining features because they don't have a cell wall. They may very easily not even have ATP either, and they can't be cultured. And they're not spiral shaped, and they don't take up the acid fast stain. So that's our category of the obligate intracellular bacteria. Chlamydia. Most likely you'll be seeing chlamydia a lot. It's a very, very common cause of conjunctivitis. It's the leading cause of blindness in the world, and the fact that it can involve extensively conjunctiva and cornea. It can also cause another STD called lymphogranuloma venereum. You're not likely to see it because it's generally not very common, but you should know it does cause LGV. And it's a very, very, very common cause of urethritis as well. You know, it wasn't that long ago where if you were to ask somebody to give the differential diagnosis of a urethritis in males or females, they would say, well, you know, in males, of course, it's either going to be gonococcus or it's going to be non-specific, which means the gonococcus can't be cultured. Now, chlamydia has taken a very, very front row in that differential as well. So a very large portion of the urethridities are chlamydia. In the family of the rickettsial organisms, which are also obligate intracellular bacteria, we have the causative agent of Rocky Mountain spotted fever and typhus, and mycoplasma as a very, very common cause of community-acquired pneumonias. That's very likely what chlamydia might look like in the eye. In this case, it's called chlamydia trachomatis because trachoma is the Greek word for rough eye. It's a very hazy, unclear cornea, isn't? This is infection with chlamydial organism. And it is, what is it, what I have down here? Affecting 100 million people worldwide. Here's another obligate intracellular bacteria causing primarily a small vasculitis. And of course, a small vasculitis might not sound like it's going to be terribly bad, but what if it's widespread? What if it's in the brain? What if it's in the kidneys? And basically, people that are very, very ill with Rocky Mountain spotted fever, also having a characteristic rash, it looks a lot like measles, will very likely be having this perivascular infiltrate. And of course, they would have gotten it in the United States from a tick known as Dermacentor andersoni, having this characteristic feature, or less likely Dermacentor variabilis. Okay, so I think we have basically another category here called fungal. And like we said before, the fungi that you see in tissue are either going to be yeasts, you know, round balls. Maybe these round balls will have little buds on them, of which Candida is overwhelmingly the #1 likely organism. Cryptococcus is going to be the second most likely. A person with a fungal meningitis is going to be Cryptococcus until proven otherwise. It's going to be very, very easily identified in the ink prep. And the fungi, which affect primarily immunocompromised patients also, that are primarily hyphal, are always mentioned as Aspergillus and mucormycosis, now more likely called zygomycosis. That's the one thing about the microbiologists. They tend to change the names on us every few years, just when we think, you know, we have it down pat. Candida albicans, ubiquitous. It's basically on all of us. And if we become, for some reason, immunocompromised or even diabetic, and we wind up yielding to a candidal infection, it'll most likely be in a part of our body that has a non-keratinized, stratified squamous lining. Oral cavity, vagina, esophagus. That's the one common feature for most of the candidal infections. And also, you notice that these are also moist as well. So like, I don't know, I would say, I would love to ask you a question like, what is the most likely organism to affect a moist, non-keratinized stratified squamous mucosa? And that's a fungus, and of course it'd have to be Candida until proven otherwise. Very common in patient that's immunocompromised for any reason, but more likely, commonly, diabetics get this a lot as well. Here's the typical appearance of a ball. Some of them have a little ball connected to the big ball. That's a budding yeast. That's classical for Candida. There's another bud over there. And here is a scraping, and I don't believe this is a fungal stain. I believe this is like either a pap stain or perhaps a modified probably a pap stain. But do you see these little hair-like particles, and they kind of interdigitate, you know, with each other and form this kind of mass with the squamous cells? Well, those little pseudohyphae wound up growing out of those little buds there. So the reason why they're called a pseudohyphae is because they're not what the microbiologist would call a perfectly legitimate hyphae that has a septae in it. So they're non-septate hyphae, which is why they're called pseudohyphae. Here's a cryptococcus. And once again, extremely easy India ink prep. 1 drop of regular old India ink from your art store, 1 drop of spinal fluid. And if you see these round organisms with a large clear zone around them, the clear zone is about 3 times bigger than the actual organism itself, you know that that's positive for this yeast, Cryptococcus neoformans. We mentioned the molds, and I won't go into it either, but Aspergillus and zygomycosis, the most common mold infections, and you would not expect many people to get a mold infection unless, once again, they're very severely immunocompromised. Okay, now we kind of have been ignoring the superficial dermatophyte or fungal infections, and the generic all-around name for a superficial or skin infection due to fungus is a tinea. And you know, don't get that confused with the tania, the species of cestode worms. Tinea here is just a general generic name for a superficial or skin dermatophyte fungal infection. And if you wind up looking at these and trying to identifying them or culturing them or taking scrapings or doing a wide variety of things that you could do in your office, almost all the time the tenias are going to be caused by one of these 3 species. So tinea is the name for the disease, and here are the 3 major species of superficial fungi that cause the tenias: epidermophyton, microsporum, and trichophyton. You know, a lot of times you'll do scrapings of these in your office, and they'll come back and give you, from the lab, and give you a very specific a generic and species name for the organism. It's almost always going to be one of these 3. Now, this is a tinea infection of the scalp. So it's not unlogical that it should be called tinea capitis, because very often, in fact usually, it has sort of a circular spreading pattern of growth in a sort of a ring form. It also has the common name ringworm. And I don't like that name because it has nothing to do with the worm. It's a superficial dermatophytic fungus, isn't it? Here's one that's even probably less easy to diagnose, because all it really is redness in an area where a man would normally shave his beard. That's Tinea barbae. And it can be caused by any one of those three genuses of bacteria. And they could be treated with your topical antifungals as well. But one of the main things, the treatments for this, is not to shave, because the more you shave, the more you irritate it. So, you know, in the military, in the U.S. military, very often you're not allowed to grow a beard in most situations. But if you had a note from a doctor saying that you had Tinea barbae, they would let you have a beard. So when I was in the Army Reserve for 6 years, I can't even count the number of guys that would come up to me and say, "Oh, can you please write me a little note saying I have Tinea barbae because I don't want to have to shave off my beard." Tinea corporis, dermatophyte of the body. In this case, it happens to be an extremity. Also, like Tinea capitis, it has a circular, concentric sort of pattern of growth. So another name for that would be ringworm of the body. Tinea cruris, okay, common name, jock itch. Tinea pedis, okay, superficial fungal infection of the skin of the foot. And even though pedis means foot, really, if you've had it yourself, or you've seen it, or you know people that have had it, even though it's called foot, it's almost always between the either fourth and fifth toe, or third and fourth, and most commonly it's between the fourth and the fifth. It could very easily be all of them. And why it's there, I'm not too sure if I know, but I do know that if you've ever, if any of your patients ever need amputation of a single toe, you know, they're diabetic or for ischemic reasons, do you know which toe is always the most likely to be amputated? The fifth toe, isn't it? So let's just say that probably ischemia is a big factor here as well. Now, the exception to the rule, because there's always exceptions of the rule, is that when you have a tinea or a superficial fungal infection by one of those three species of the nails, it no longer has the word tinea anymore. And it has a name that looks like it's completely different. But if you wanted to call onychomycosis tinea of the nails, that would be absolutely correct, because that's what it is. And if you look at the normal large toenail here, where it's most severely affected versus the normal one, what can you say about this nail? That's onychomycotic. Is it thicker? Is it whiter? Is it less transparent? These would be all the proper adjectives you would use to describe it. What about the fungi now that are not superficial? You know, any superficial fungus can go a little bit deep under severe circumstances, but what about the fungi that routinely go deep? And those are always referred to as the big three: histo, blasto, and coccidio. And what do all of these three diseases share in common? The deep fungal infections. Well, is that they all mimic TB, and they all have a very specific epidemiology into where they're found and how they present. But if you remember, if you have a patient with multiple granulomas in the lung, sometimes they're very, very well delineated radiologically, and very, very often they're much more likely to be calcified than tuberculosis as well. You know, it's probably going to be one of these three things until proven otherwise. And then the diagnosis basically depends on where did they live. Do they live in the Ohio Valley area? Do they live in the Arizona region? So it's generally, with some overlap, it's usually a region of the United States that's more likely to get one than the other. But in terms of pathologic identification, the big feature here is size, because both blastomycosis, coccidiomycosis, and even histoplasmosis are basically small individual round balls or yeasts, right? But the tiniest one is histoplasmosis. So when you have a cell here that, let's say the nucleus is 10 microns and the cytoplasm might be 30, the typical size of a histoplasmosis organism is only about 3 microns. That's less than half the diameter of a red cell. They show up as just fuzzy little granules within macrophages. In blastomycosis, you have balls pretty round in configuration, in this case taking up the PAS stain very nicely. And in coccidio, you also have balls. They are also yeast, but look at, they're twice as big as blasto. So this would be a good general formula for differentiating them. Histo is the smallest, coccidio is the biggest, blasto is in the middle. And compared to blasto and coccidio, histo is extremely small. Here's a picture that somebody sent on one of the internet forums that I belong to, a pathologist forum. And even though you may go to a nice textbook or Google something that shows the organisms, I've never seen one as beautifully demonstrated as this. These are macrophages or histiocytes, and the histoplasmosis organism is just a very tiny fraction the size of a nucleus. So it's, it's only a couple of microns, causing a sort of a fuzzy pattern. Okay. I think the last thing that we'll do, even though I'm sure you've done this in microbiology, is talk a little bit more about the protozoa and actually go into the life cycle again of malaria. Malaria, not only the single biggest protozoal disease of clinical importance, but the single biggest parasitic disease of clinical importance. We'll talk about the life cycle and the identifying features in the lab, how to separate, one of the 4 species from the others. I think we'll mention briefly, we mentioned before, we're not going to go into it, another protozoal disease called babesiosis. I'm sure you may have heard of that. We're not going to say anything more about it. We also mentioned leishmaniasis, also protozoal disease, in which the protozoan actually gets into the cell, and although it's primarily a protozoal infection of skin and subcutaneous tissue, it can often go deeper. We'll say a couple words about the trypanosomes, both African and Central American disease. And we'll also just mention again, as part of the taxonomy, that Entamoeba histolytica is also a very, very big protozoan of worldwide importance. Let's start out with the big one. That's the Anopheles mosquito. If you saw that, could you differentiate that from any other mosquito that you might have here in the Caribbean? Probably not. I'm sure there's ways of doing it, but let's just say that's the mosquito. It's already done its damage because there's a whole bunch of blood there in the abdomen. Life cycle, like all of the parasites, is both asexual and sexual, and once the gametes join, that's the beginning of the sexual cycle. There's fertilization, and that largely takes place outside of the human body. Sexual cycle here is in the mosquito, because the mosquito, not only will he put in the sporozoites into the human, but he'll be taking out the gametes for development in his own body. So you have the fertilization of a male and female gametocyte developing into a zygote. This is all in the mosquito, undergoing the meiosis, and then forming an oocyst in which contains many, many sporozoites. The sporozoites then get injected into the human bloodstream, and the first place they go is the liver. They infect the liver as the first thing that a malaria infects when it's introduced into the body. These liver cells then develop many, many tiny little particles called merozoites, which will then get into the red blood cells and undergo a whole new pattern of maturation as well. So, is there any way we could make sense out of this? Well, we could say that the sexual cycle is largely in the mosquito, the asexual largely in the human. And I think you should remember the very first organ is the liver, and before you get into the red cells. And on an actual smear, regular old right stain smear, something you'll be looking at in your own offices, is that they often may look like there's tiny little either platelets that are overlaying the red cell, or little ring forms or little schizons which develop from the ring forms, which make the identification of malaria pretty easy. Even though it's generally pretty easy, these may not be very common. You may look at, you know, several thousand red cells until you see one that either has a ring form or a schizont. And once you see them, you'll probably find more. And what I'm going to do now is to try to help you differentiate some of the key features. You know, the most significant form of malaria, the one with the highest mortality, is falciparum, Plasmodium falciparum, also the one that's most likely to be resistant to anti-malarial drugs. And each of the 4 types of malaria has a something about it that's a little bit different from the others, and I'm just going to try to zero in on that. And that doesn't mean you're going to see them right away if you're in the lab or in your office. And even if you see them and you think it's one kind of malaria versus another, very often it winds up being whatever type of malaria is endemic to that area. So I've seen people that a lot of times a slide will come into the lab and everybody will jump on it and start looking at it and saying, oh, is this a large gametocyte? That means it's falciparum. Or are these Schuffner's dots, which means it's something else? And then they always wind up coming up with some diagnosis. And if the diagnosis is correct, it's almost always what everybody else in that area has anyway. So, just to show you, when I say a ring form is one of the early forms to develop once those merozoites get into the red blood cells, the last form to develop is a gametocyte, and that's the form that will eventually go back into the mosquito. And it's usually in the red cell. In this one, it looks like it's kind of escaped from a red cell. And there's also going to be some form between the ring form, which is an early form of the red cell infection, and the gametocyte, which is a late form of a red blood cell infection called schizons. And we'll probably show you a picture of that as well. So let's go through the 4 types. We might as well start with the one that's the most feared, has its own characteristic region of distribution. I could probably draw you world maps for all of these. And the thing to remember about falciparum is that the gametocytes, which is the last stage before it goes back into the mosquito, are the largest of all, and they're sausage-shaped, and they're the most numerous. Another thing to remember about falciparum, see, here's some ring forms here, here's the schizons here, you can see the difference. Here's the later stages, the gametocytes. Another thing to remember about falciparum is that they don't have cytoplasmic dots, the so-called Schuffner's granules. 2 of the others do, but falciparum doesn't. So let's differentiate it from the next type, which is called Plasmodium vivax. Yes, you still have ring forms. Yes, you still have these, what looks like multiple platelets on top of a red cell, the schizons. Yes, you can still have a gametocyte, but they're not sausage-shaped like falciparum. But what else do you have? You have these little red dots all throughout the rest of the red cell, after the ring stage forms. And those are Schuffner's granules, or Schuffner's dots. And you get Schuffner's dots with both Plasmodium vivax and Plasmodium ovale. So you can't say it's specific for one, but there's something about ovale that makes it different from vivax. Okay? Well, here's the fourth one. Here's Plasmodium malariae. Does not have big gametocytes, but like all the others, it'll have a ring form, it'll have schizons, but it doesn't have Schuffner's granules, doesn't it? And another thing to remember is that when you're looking at red cells that are affected by malaria, usually those malarial organisms cause that red cell to increase its MCV. It looks like a macrocyte. It's pretty much bigger. But in malaria, regular old Plasmodium malariae, the red cells are usually not enlarged. They're usually the same size as the others. So, we've already talked about vivax with the Schuffner's dots, and probably and differentiate from the other one that has Schuffner's dots, the malaria, because the ovale and the vivax have Schuffner's dots, but ovale has this other little thing which is quite diagnostic, and it makes it totally unique from the others. It's called a comet form. And if you remember, we talked about these little ring forms and then the schizons, but there's a stage between the ring and the schizont, and it looks like the ring is broken, and it looks like it's a comet with a thick, sort of bluish or basophilic area with a nice curved tail to it. So that's the diagnostic feature of Plasmodium ovale. And whether you're ever in a position to have to differentiate between the two, I suspect someday you might. You're probably going to wind up getting the books and trying to remember what is what again. And ultimately, if you do come up with the right identification, most likely it's going to be what was the predominant thing in the area anyway. Trympanosomes. Classical trympanosome diseases, trympanosomiasis, Africa. This is the tsetse fly. If you were to look at it and to compare it to any other fly, you would say, well, it kind of looks like any other fly I've ever seen, but it seems a little bit bigger. And there are some ways to differentiate it, which I won't go into. People that have been bitten by this tsetse fly and have developed the sleeping sickness, because that's one of the features of the disease, may very easily have these tiny little wavy parasites, not quite as big as red cells, and these are the trypanosomes. And if you have the African variant of disease, it's called trypanosomiasis, or sleeping sickness. There is something that's similar in South and Central America, also trypanosomes, called Chagas disease. Okay, we went over this before, and I don't think we're going to go over it again. Just to mention again that, the only two types of worms that are parasitic to humans are the roundworms, the tanias, and the flatworms, or the cestodes. And we went through the life cycle of Ascaris already as a classical one for a roundworm. Know that Strongyloides is another one. Know that all of the tapeworms are in the phylum Platyhelminthes, platy being the Greek word for flat, because they're all flatworms. And they're either going to be from beef or pork, most likely. They could come from a fish or be that dwarf tapeworm. The worm causing schistosomiasis, especially in the Mideast and especially in Egypt, is very, very likely to be involved with bladder cancer as well. So when we get to the chapter on lower urinary tract, you're going to walk away thinking that just about every epithelial cancer of the bladder is transitional cell, because those are the cells that line the bladder in your lower urinary tract. Well, if you're in Egypt, the main epithelial malignancy of the bladder is a squamous cell cancer, because if the disease is so predominant there, schistosomiasis causes a major squamous metaplasia of the transitional mucosa, and then that very often goes into develop an actual squamous cell carcinoma. Now, does that mean that schistosomes, cause cancer? I wouldn't go that far, other than by saying, the routine hepatitis B virus, causes hepatoma. But it goes into the cycle of changes which ultimately may result into a malignancy. And the small filarial worms, filariasis, very often plugging up the lymphatics, which they can do, might cause a condition called elephantiasis. You've seen them all. I don't think I've ever seen a pathology book that didn't have a picture of, somebody's scrotum hanging down to their knees practically, simply because the lymphatics of the lower extremities were completely plugged with these little worms. And once again, metazoans, these would all have complex life cycles. We've done that, and we've done that, so I don't think it's worth doing again. But what I can say is we did a whole bunch of material, and I'm really, really glad that you had more details of some of these in your course in microbiology. So we'll say officially we're done with the part of the course that's the presentation. We're going to have a whole bunch of cases tomorrow in the lab. We should be looking at some of these diseases and seeing some of the organisms. And then after that, we'll have a nice review. No reason to not call it a day right now. Thanks for your patience in bearing with this pretty long, complex chapter. Okay. Good time to play a closing song.
Welcome to the Hotel California. Check out anytime you like, but you can never leave.
Probably most of the jobs in the most of it we're going to have in the middle. That's something I can drop up every now and I'm going to find out the answer. Were you all able to hear the audio very well today? For those of you that are still here, just type in your answer. I'm hoping you did. Uh-oh, I see a yes and I see a no. I see another yes. Well, I'll be making a movie and playing it, and I know it's going to be infinitely better than yesterday. So, and I don't feel so bad sitting down here at the bench either, although I'd rather be walking around. So, until tomorrow, same time, same place, I will be seeing you, and rock on. You buzzards.